Hey guys, I have been trying to get this recorded all day, but hopefully now we'll get it recorded. Anyways, the neural system. This is actually my favorite um, unit in this class. Um, when I was in school, I hated the neural system. It just did not make sense to me. Now that I've been out and about and got more experience, I love neuro. So there is a lot of topics to go through, and it gets to be quite lengthy. So we'll see what we can get through. Maybe. If I can get this slide to switch. There we go. We're going to skip the learning objectives. All right, so the nervous system, what does it do? It detects changes in their bodies. It feels sensations. It responds to those changes. Um, it can organize and store information and provides conscious or unconscious awareness. So they know what's going on, whether the person is conscious or unconscious. Generally, if there's issues in the neural system, the symptoms are going to be pretty vague and they're very hard to pinpoint. But we'll get into each disease process and it'll make a lot more sense. So A and P of the neural system. The basic um, cell of the nervous system is called the neuron. This is the cell that transmits messages or impulses from one cell to the next, from the brain to the muscles. The myelin sheath. This is, I compare it to like the casing on a hot dog. We'll get into, once we get into MS, it'll make a lot more sense, but I want you to think of the myelin sheath as the casing on a hot dog because it's just basically the insulation that protects the axons. I think I do have a picture pulled up, so this will make more sense if I can find my picture. So yeah, so when we talk about the neuron, it's this whole thing here. When we talk about the myelin sheath, it is these coverings right here, the little yellow casings. Axon is this purple thing underneath the myelin sheaths, and this part right here, this side of the neuron is called the axon. That is what carries it from the cell body to the next neuron. These myelin sheath, the covering it's actually a white, makes everything white. Um, so axons that are myelinated are considered what you hear called white matter, and axons that are not myelinated is what you hear as gray matter. So that kind of makes sense when you're talking about like brain tissue. The actual brain tissue is called gray matter. So um, the neurotransmitters actually hang out down here and help um, the impulse get across this synapse here onto the next neuron, or stops it right here. It doesn't do both, but certain neurotransmitters help the impulse move to the next one, and certain ones stop that impulse from moving to the next one. And then these little ends here, those are the synapses. Um, from like at the end here up to the next, like the dendrite. I hope this all makes sense. I wish I was in front of you guys. It would make life a lot easier for all of us. Um, so let's go back to our PowerPoint. All right. So I did have a slide that kind of goes with this one. I just want to go through a couple FYIs, a couple things so you guys understand the material a little bit better. When we have issues in the brain, that the brain needs oxygen or glucose, that's a problem because the brain cannot store either one of those. So if there's a problem blocking the transmission of oxygen or the transmission of glucose because the brain needs lots of sugar to work, that's where the issue comes in because there's no way for the brain to store either one of those. So the central nervous system is the brain and the spinal cord. The peripheral nervous system includes the autonomic nervous system, which includes the sympathetic and parasympathetic systems. So the sympathetic system is the fight or flight response, controls things like the heart rate, respiratory rate, and the parasympathetic system deals with slowing the body when it needs it. Deals with things like digestion and reproduction. It's called the feed and breed system. There are 31 pairs of spinal nerves that exit from that spinal cord. And I think that's all my notes that we'll go over. Oh my god. Yeah, we'll skip that one too. So, basic neuro assessment. Now I have lots and lots of notes on this one, so this one's going to be quite a bit. So, in our basic neuro assessment, it is just go in, check the neuro system. It's more of a focused assessment, but I'm going to go over all of the parts of a neuro assessment. So the biggest thing when we are doing our neuro assessment is to note their level of consciousness. Anytime there is a decreased level of consciousness, there's a huge, huge red flag for neuro issues. So what we're looking at, consciousness is the degree of alertness or amount of stimulation that's needed to engage a person's attention. So they can be awake, they can be engaged, and or alert means they're awake, they're engaged, and they're responsive. Now, a person can be alert, but they may not be oriented to person, place, or time. So it just kind of depends on their situation. But just know that a person can be alert without being oriented. Another thing that we need to look at is if they're lethargic. Maybe they're drowsy, but they're easily awakened. You walk in the room, they hear you, they wake up. Or maybe you say their name and they wake up. That would be more lethargic. They might be delirious, where they're having confusion and agitation. Obtunded, where they really don't have a whole lot of response to environment stimuli, whether you're coughing, whether you're calling their name, whether you're clapping. They just really don't have very much of a response. Stupor is when they are responsive to vigorous stimulation only, like painful stimulation where you rub their sternum. And coma, basically, this is where there's no response, no matter what type of stimulus you're doing. And then death is final, obviously. They're going to go over normal verbal and nonverbal responses. Of course, with every neuro assessment, you're going to do vital signs. Pupillary response, the PERLA, pupils equal and reactive to light and accommodation. But some things to kind of think about is if a person has had eye surgery, whether it's for cataract or glaucoma, their pupils might actually be irregularly shaped. And same thing if they have eye drops. Maybe they're only being treated for glaucoma in their left eye. Well, that eye is not going to be responsive as much as the right eye. So make sure you know your patient, what they're being treated for, what their surgical history is on their eyes. Because they will throw you off. I had a patient once who had a fall, and the 3 nurses ahead of me had actually charted that the pupils were round and reactive, and when I went to check their pupils, they were not reactive. Well, yeah, that's because they had surgery, and they didn't catch that. When we're checking their pupillary response, know that we're checking their cranial nerve number 3, the oculomotor nerve. What's next? Strength and equality of hand grip and movement of extremities. So these are we're going to be looking at involuntary movements, whether there's tremors of both hands, but I also want you guys to know that there is a strength scale out there, so that when you're doing your neuro assessments, you're not just going to say positive, yes, they squeeze my hand, or check mark. I know it's kind of how things have been taught earlier, but I want you guys to know that there is a scale out. So 0 to 5 is basically no contraction, nothing. The muscles are not doing anything. 1 out of 5 is a muscle flicker. There's no movement. The patient is not moving their arms at all. 2 out of 5, there's movement possible, but no movement against gravity. Like, they can't fight gravity to actually move. A 3 out of 5, there's movement possible against gravity, but not if you, as the person who's assessing, hold their extremity, and have lift your leg against my hand. 4 out of 5 is movement possible against some resistance by you or the examiner, and then 5 out of 5 is normal strength. So make sure you guys are doing those when you're doing your assessments, because it will make all the difference in the world. Cognition, I want you guys to kind of understand the definition of that. And it's basically, cognition is the integration of mental processes, functioning for purpose of reasoning, learning, memory, and personality. You guys will, once you get out on the floor, this will make so much more sense. And I can't wait till you guys can actually get back in clinical. So when we're looking at orientation, I don't know why that's right there, but things that we can assess and we can ask is their ability to relate their onset of symptoms of whatever issue they have going on to what's happening. We're going to ask them the name of you, their nurse, or their primary care doctor. We're going to ask them the date, or maybe just the year and the month, depending on their baseline. We can ask them things like their home address, and we can ask them, what healthcare facility are you in? Are you in, my usual thing is, what type of building are you in? Are you in a school? Are you in a hospital? Or are you in a grocery store? And depending on their, whether they're demented or whatever, you get different answers. All right. Another thing we're going to look at is their ability to sense touch or pain. We're going to have them stick out their tongue and do other ones like the where they're holding their arms out with their palms up. If they close their eyes, sometimes if there's neuro issues, one of their palms will like drift inward. It's called the pronator drift. If that hand kind of turns and they can't keep it straight when they're not looking at it, there's neuro issues. And then there's the type ones where their providers assessing for their cerebellar function. So that's when they do like take your right heel and slide it down your left shin, or put your palms up on your thighs and flip them back and forth, or where they have you stretch your arm with your finger pointed out and touch your nose with your eyes closed. Yes, I know you guys just probably tried it. Haha. They might have you walk across the room, and then walk back, maybe one foot in front of the other, maybe on tiptoes or heel toe, just to kind of check and see where the issues are with their neuro assessment. And it's our job to identify any changes from baseline. So I think that covers that slide. Here is the Glasgow Coma Scale. You'll hear it called the GCS. This is what many providers, all providers use to determine their level of consciousness for their patients. Anytime there's a decrease in level of consciousness, we worry about neuro issues, which the biggest, biggest cause for decreased level of consciousness is increased intracranial pressure. But people can have decreased level of consciousness with different things like hypoglycemia, hypoxia, or even intoxication. We were at Country Boom, and I didn't know it at the time, but my friend's kid was drunker than a little rat, and they actually scored him a 9 on the GCS. My cousin was the EMT out there, and they scored him a 9, and they were getting ready to intubate because after under 8 and under you intubate, but he was just intoxicated. So all right, moving on. ICP. So increased intracranial pressure. If you think of it, the biggest or the easiest way for me to understand ICP, is you have a closed ball. In that ball that does not move, there's a brain that takes up 80%, there's blood that takes up 10%, and there's cerebrospinal fluid that takes up 10%. So if there's swelling, herniated brainstem herniation, any of that, anything where, say, the brain takes up 85%, the other 10% have to accommodate that, but they don't. So it just causes this abnormal pressure within that lemonade on my computer, causes increased pressure in that ball, in the skull. Things like brain trauma, when the brain gets hurt and swells, hemorrhage because there's more blood and there's no place for the blood to go, or tumors, where they actually take up large amounts of space in the brain. So sometimes they might actually put a catheter in there to try and drain some of that stuff from the head. You guys have all seen Grey's Anatomy, and they drill burr holes in everyone. But the burr holes will actually decrease intracranial pressure. Things to avoid with people with increased ICP, suctioning is a definite no-no, and anytime we want to try and get them so they're not flexing their hips, because I'm not sure the science behind it, but that will increase ICP. Symptoms that we're going to see are behavioral changes, headache, nausea, vomiting, increased blood pressure, double vision. Late symptoms, trouble breathing, heart rate's going to slow down, pupils may not respond, they may go into seizures or coma. I had a friend, well, it's my daughter's friend's dad, had a tumor the size of a softball in his head, and he had all of these symptoms, but they diagnosed him with bipolar. So he eventually went into seizures, and they found the tumor. So, what else do we want to tell you? Treatment for ICP, mannitol, because it will draw the fluid out of the brain, and then the kidneys will excrete it. And then it's also given, a loop diuretic is also given to get rid of all that fluid. And then the catheter, like I told you. Can't wait to get into this. diseases and illnesses. Things that increase ICP, told you, suctioning, hip flexion, some simple movements might cause it, coughing, sneezing, bearing down, swelling. What do we need to do as a nurse? We need to make sure we're educating the family members so that they're recognizing signs of the ICP increasing. Anytime we have a brain injury or something going on with the brain, we really need to keep the stimulation down, low stimulation, low lighting, quiet, and then try and decrease stress as much as possible in there. Monitor the orientation level really, really closely. And then we need to make sure that we're waking people up during the night and checking their neuros. You don't want to work night shift and have them go to bed at 10 o'clock and you go in there at 5 o'clock in the morning and their ICP is through the roof because you didn't catch it early enough. What can we do to help? When you have somebody with increased intracranial pressure, you're going to see the head of their bed elevated, only about 30 degrees, but you just want to keep them so they're not extremely high up, but some. All right. Decorticate and decerebrate. These are the positioning of the body depending on where the damage to the neural system is. So if there is damage between the brain and the spinal cord, you're going to see these people kind of curling inwards. So it's called decorticate. So if you think of it curling towards the core, this is damage between the brain and the spinal cord. So you can see picture B here is the person curling inward. Clenched fists, their legs are going to be extended, but their feet are going to turn in. They're going to be rigid. In decerebrate, they're going to be more extended. Their toes are going to be extended outwards. Their arms are going to be extended. Their hands are. And this is when there's damage to the brainstem. All right, headaches. Most people get headaches here and there. The biggest worry is when these headaches become from just a normal headache of I was out in the sun and I got too much sun today, into something that is not the person's normal. There's a million reasons for headaches, and many people. This is one of the top reasons that people go to visit urgent care. The tension headache, basically, this is a persistent contraction of those blood vessels to the brain. Cluster headache is just back to back to back to back. Migraines are a little bit different because the vasculature in the brain actually constrict and then they dilate and there's more blood flow and there's causing inflammation to the area. So a lot of times migraines are unilateral, but to that area there's more inflammation right in the veins and arteries and all of that. So in a migraine, they constrict and then they dilate, and when they dilate, that's where the pain is. What can we do? We need to help educate our patient and find out what their triggers are. Migraines, a lot of times, certain smells can be triggers, certain situations can be triggers. Medications, we need to educate our patients on types of medications to take. I think we get into that in a little bit. Yeah, we will. And like lifestyle and environmental issues. So if a person is suffering from a headache or migraine, we're going to teach them to go in a quiet place, in a dark room, where they don't have a lot of stimulus, where they can lay down and try and sleep. If they are in the ER or wherever we're working, we can do simple things like pull the curtains and put the lights on dim, give them a warm blanket for their head, which some like that, some don't. I prefer not to use it on patients because their veins are already dilated. We don't want them to dilate anymore. So I always try ice packs. Um, yeah, we can help them out no matter where they are. So this is a nice little chart um, that tells us the difference between the tension, the migraine, and the cluster headaches. Some things I want to cover is for migraines. Triggers, like I talked about, might be stress or weather changes, maybe when people get hungry. Different types of food can actually cause migraines. Red wine, cheese, chocolate. Sometimes when people fly, they end up getting a migraine, birth control pills. Um, a lot of times, migraines can be triggered by hormonal changes when women are getting their menses. Um, So, anyways, one of the biggest meds that people take for migraines are the triptans, sumatriptan. You guys have probably heard of like Imitrex. Um, what these do is they basically treat acute migraines. A lot of times when people get migraines all the time, they are given these to be taken at home. That can be a pill, that can be a shot, whatever works for that patient. But the triptans actually vasoconstrict those dilated blood vessels. Um, so when they vasoconstrict those dilated blood vessels, it actually improves the blood flow to the brain. I know I said that the blood vessels actually dilate with a migraine, but there's so much inflammation that the blood flow isn't what it needs to be when somebody's having a migraine. So when they can actually reconstruct those blood vessels, the blood flow is a lot better. And that's why the headache will go away, is because there's appropriate blood flow to the brain. Prophylactic treatments for headaches, migraines. Um, you can do diet changes depending on what the triggers are. Sometimes people take beta blockers, calcium channel blockers. It just kind of all depends on what the provider prefers. All right, I think I'm going to pause here for a minute, and I'll be right back. All right, I'm back. So, starting on seizures and epilepsy. So, you can have seizures without being epileptic. Uh, it becomes epilepsy when a person has had 2 or more seizures. Um, there's different types. There's the partial seizures and there's generalized seizures. Um, Basically, what a seizure is, it's a sudden explosive discharge of the cerebral neurons. Uh, Probably one of the most common neurological disorders that you guys will see. So, in a partial seizure, that discharge of cerebral neurons is only on one side of the brain. It can be a complex partial or it can be a simple partial. It can last anywhere up to 15 minutes. And partial seizures are these repetitive, purposeless, I can't say that word, purposeless behaviors. It can be different things like rubbing their knees or spitting or fondling. Sometimes these behaviors are actually unacceptable, and people just need to realize that this is their seizure pattern. These people are going to be in a dreamlike state, and they're going to have kind of like an amnesia effect to it. um, they may or may not lose consciousness. So partial seizures, remember, they're one-sided, and they're more like mannerisms rather than actual what you think of when you think of seizures. Um, Absence seizures can happen with kids, um, where they just kind of stare off into space. Um, these are the actual generalized seizure. These are full brain seizures. Um, you can have tonic-clonic seizures that are generalized. Um, kind of jumping all over here. Um, the tonic-clonic ones are probably what you think of when you think of a seizure, where the patient will like tense up, and then their body will twitch and jerk. It's very scary. If you guys have ever seen a seizure, it's not something you will ever forget. So when they have these tonic-clonic seizures, their body's rigid. They're going to go into convulsions, which is like the twitching or the muscle spasms. Their jaw's going to clench. Sometimes they're going to lose bowel and bladder. Um, they'll be incontinent. They'll drool. And when their body gets so tense and so rigid, they can actually stop breathing. Um, some of the bad ones that my daughter's had, she's turned blue. Um, but there's really nothing you can do. You just need to keep them safe. Because they will, if they're standing or walking or even sitting in a chair, they may fall. Um, we've been lucky with Ariana that there's only been one time, and I don't know what she was doing, but she had stepped up onto the couch, and my husband literally caught her as she was falling backwards. She would have just smacked her head right on the floor. Um, but she stood up on the couch and went into a tonic-clonic type seizure and just fell backwards. Um, Postictal period is the recovery period after a seizure. They're going to be very tired, can last up to an hour or even a couple hours after the generalized seizures. Generally, they don't have them after the partial seizures, but they um, will have them after the generalized seizures. Um, they might be confused, um, have a headache. They're not going to remember their seizure, especially during the postictal period. Um, yeah, trying to think of anything I missed. All right, so diagnostics for seizures or epilepsy. They're going to be done what's called an EEG. It can either be a sleep deprived EEG, or it can be just an EEG done to see if they can catch a seizure on record. Um, medications that they're going to be on are called anticonvulsants. Now, if you think of like gabapentin, just remember that there are off-label uses for some of these meds. With somebody who is on seizure meds, they need to have a level monitored very closely because people grow, their metabolisms change. Each person is different. So what may work in one person doesn't always work on the next. Their drug levels need to be kept at a therapeutic level because if it's too low, they're going to go into seizures. It's not going to be helping with anything, and it also can't be too high either. So that is one of the biggest, most important things to know when you're treating somebody for epilepsy or seizures is to monitor their drug levels, whether it's Dilantin, Tegretol, gabapentin, Neurontin, um, Lamictal. Anytime they're on meds, they need to have their therapeutic levels monitored closely. Kidney and liver function are also important to watch because those drugs can be hard on the body. Never ever, I mean, always teach your patients to never ever just stop their meds. They can go into static epilepticus, which is in the next slide or so. Um, so, seizure precautions. In the hospital, they look a little bit different than they do at home. But if these people are in the hospital, an old school thing is the padded side rails. I know I was reading in the book that it said that they don't always do padded side rails anymore because it's a dignity issue for the patient, and it doesn't always help having the padded side rails. But I think as of right now, most facilities I know do have padded side rails. You need to make sure we're keeping sharp objects away from them. And when you have somebody who is in a seizure, there's no way to stop the seizure. So basically, don't hold them down. Don't try and stop their movements. You need to make sure that we're placing them on their side. Make sure there's nothing in their mouth. Long time ago, they used to say to keep a padded tongue blade at the bedside. And they used to literally put this padded tongue blade in their mouth to keep them from biting their tongue, because that will happen too. But people were biting off the tongue blade and choking on it because their mouth would clamp down so hard. So that is a thing of the past. So we just make sure that they have nothing in their mouth. We need to make sure that we're documenting the length of the seizure from the time it starts to the time it stops, and note if there was anything that may have precipitated it. Sometimes people will be able to tell you that they have an aura or smell something or just feel different, and we just need to make sure we're documenting that, asking them if they felt any different. So when you have somebody who's having a seizure, make sure to put them on their side. Our biggest thing is to keep them safe. We want to make sure that they're on their side and they're not bumping into furniture, nothing in their mouth. Just keep them safe until their seizure is over. So this is what I was talking about. People who abruptly discontinue their medications are at a huge risk for static epilepticus. It is a medical emergency. It is 30 minutes of repetitive seizure activity without return to consciousness. It can be one big seizure, or it can be back-to-back seizures. It doesn't have to just be one, but it can be just 30 minutes of the seizure activity without them coming back and going into their post-ictal phase. Like I said, it's because people stop their drugs, and when they go into static epilepticus, it actually increases the oxygen needs by more than 60% and the glucose by 250%. So remember I said the brain cannot store glucose and oxygen? This is no exception, and it uses so much it needs so much of that to function properly. Again, nursing care during a seizure, I think we've gone over this, but we need to make sure we're protecting their head and their airway. They're in a safe environment, and treatment with like lorazepam, diazepam, or Dilantin. What is it called? We call them Aries butt darts. It's Diastat, which is actually a rectal form of diazepam or Valium, and that should stop the seizure. For static epilepticus, these people need to be seen and transferred to the ER. In somebody who is diagnosed with epilepsy, the rule of thumb is that if you have to administer their emergency med, you call the emergency services right away. But if they are coming out of it and you feel comfortable, you can keep that person at home. But general rule of thumb is if you have to administer their emergency med, the emergency services need to be called. Whether they transport or not, then that just kind of depends on how the person's coming out of their seizure. The big problem with static epilepticus is that when they are going into so long of seizure activity, remember I said that they can turn blue, they can tense up so much that all their muscles are just spastic. It can actually cause hypoxia to their brain, which leads to so many other issues: mental retardation, dementia, aspiration. So that's why static ellipticus is such an emergency, because it actually cuts off the airflow, the oxygen to the brain. All right, TBIs. TBIs are so widespread. It's just any type of trauma that results in a hemorrhage, a contusion, a laceration of the brain to that cell, to those cells. Um, can be minor effects, all the way up to vegetative state. So concussions are called a TBI. Contusions is basically just a bruise on the brain tissue. Um, and a hematoma is like an actual blood bubble. Um, Depending on where it's at with the hematoma, the symptoms will be a little bit different. What do I want to touch base on? Contusions or bruising or that diffuse axonal injury may actually be caused by shaken baby syndrome. The subdural hematomas, again, it gets to be where it's located. That's what makes it a subdural hematoma or an epidural hematoma. Just depends on where it's located in the layers of the brain protection. The subdural hematomas may be more common in elderly and alcoholics because of their risk for falling. You'll hear a closed head injury and an open head injury. A closed head injury just basically means that the skull is intact, where an open head injury is a break in the skull, whether they hit their head on the cement or had a, oh gosh, my brain is fried today. Something that stabs into their brain through their skull into their brain. TBIs are physical, they cause so many issues: physical, intellectual, emotional, social, into someone's life. They are a nasty bugger. My daughter actually got one at work. Oh, back last summer. Um, and it was terrible to watch. She wasn't even able to function as a normal 19-year-old. All right. So, moving on. For a TBI, our first priority is respiratory status. Make sure that their respiratory status is intact. Make sure they're breathing, because if they ain't breathing, they ain't doing anything else. Then we're going to look at their level of consciousness, blah, 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 and do their neuro checks. But the first thing we need to check is their respiratory status. Diagnostics. There are going to be CT scans. There's going to be MRIs. Just to see where that injury is and what type of injury it is. Our job, we're going to help control the intracranial pressure, support their body functions. A lot of times these guys are going to be one-on-one care because TBI patients are very impulsive. They do not have that, hey, I shouldn't be doing this, and literally just go do what they, the first thing that pops into their head, I should say. TBIs are very difficult on the family because sometimes the patient doesn't even realize what's going on, where the family is actually taking care of them. And they know the person before it happened, and they see how it's affecting that person. Yeah, when Maddie had her head injury, they were probably documenting that I was crazy, insane. I had a doctor tell us that she just needed to wish her symptoms away, and I kind of lost it. So just be supportive of the family because they're seeing it as a whole picture. Especially with TBIs, for medical management, make sure we are decreasing stimulation. That's TV, screen time, visitors, lights. We want to keep the lights dim. We want to keep the number of visitors to a minimum, just so that if you think about it, if you have a cut and you're constantly rubbing it, scratching it, that cut's never going to heal. So if you have a TBI and you're constantly having stimulation and working that brain's never going to heal. So no matter what the person is doing, if they aren't, stopping their screen time or trying to stay out of a stressful situation, um, it's just like basically like rubbing and scratching a cut, because that cut's never going to heal. All right, gonna take a quick break. Hello, I'm back. All right, infections that bleh, what is it? Infections that affect the brain. All right, so meningitis. Basically, this is the inflammation of the membranes, the meninges, and the CSF fluid surrounding the brain and the spinal cord. It can be viral, it can be bacterial. Um, Bacterial is pretty rare, um, but bacteria is generally the one that is more fatal. This happens quickly. So what happens is the person gets an infection somewhere, spreads through the bloodstream, invades the central nervous system. The meninges become inflamed, and that ICP goes through the roof. For diagnosing meningitis, for treatment, they need to know whether it's viral, whether it's bacterial. So they're going to do a lumbar puncture to actually look at that CSF. When you look at CSF for bacterial meningitis, there's going to be a huge increase in white blood cells in that CSF. So bacterial meningitis, you're going to see increased white blood cells. Viral meningitis, you're not going to see that increase. So symptoms of meningitis, the cardinal symptom is this neck stiffness, and that's because those meninges are inflamed. You're going to see a headache caused by the tension on the blood vessels and the irritation of the dura mater in the brain. You're going to see nausea, vomiting. They're going to have a fever. They're going to be sensitive to light, sensitive to sound. They might be confused. They might be sleepy. Might actually have seizures because of the increased ICP. Initially, people mistake meningitis for like cold and flu symptoms and kind of poo-poo it until the symptoms get worse. You might also see things like nuchal rigidity. My twin nephews had Hib, and that is one of the things that can cause meningitis. So prevention of meningitis is the pneumonia vaccine, the Hib vaccine, and there is a meningitis vaccine, especially made for college kids because of their close living proximities. Sorry, I'm trying to do too many things at once. Sandra's texting me, so if you can hold on just 1 second, I gotta pause it again and answer her text. I'm back. Sorry about that. I actually turned my phone off so we can finish this. All right. So meningitis symptoms, like I said, the fever, the neck pain, they're going to be sleepy, they might be vomiting, they're going to have pain in their joints, rash, headache, seizures, light sensitivity. I do want you guys to know the Brudzinski sign and the Koenig sign. The Brodzinski sign, when the person's neck is flexed forward, the hips and knees will involuntarily flex up, and that just shows that there's meningeal irritation. Koenig sign is where you flex one of the patient's leg at both the hip and the knee, and then straighten their knee. There'll be pain and increased resistance when that knee is extended, when there's irritation to the meninges. So make sure you know those. Like I said, there's viral and there's bacterial. Every patient needs to be treated as if it's a bacterial meningitis until bacteria is ruled out, because bacteria will cause death a lot quicker than viral. And if you're waiting to find out if it's bacterial or viral, you're losing that time treating the bacterial infection. So when they have their lumbar puncture, that CSF for a bacterial will be cloudy, turbid. With a viral meningitis, it's going to be clear. Like I said, there's going to be a huge increase in white blood cells for bacterial and only a slight increase for viral. You're going to see bacteria counts positive, obviously in a bacterial, and negative in the viral. In bacterial meningitis, their glucose level is going to be low, and the viral, their glucose is going to be normal. In a bacterial meningitis, they are going to have increased intracranial pressure, and viral meningitis rarely changes the ICP. So bacterial meningitis can actually start as like a pneumonia or a strep infection, like a strep throat. It can actually hit the bloodstream. The person can go septic, and it can travel up to their brain. That's how it goes from being a normal strep throat up into meningitis. So it can actually travel and start from, something as simple as a strep throat or pneumonia. Trying to go look at my notes here again. Like I mentioned before, the bacterial meningitis has a lot of causes, but the bugs that generally cause it are the Neisseria meningitis, the Streptococcus pneumonia, and the Hib. I think sometimes I should just not look at all my notes because it makes me nervous with my boys having Hib. It just makes me realize how lucky we were. Viral meningitis, these people are actually going to basically, it kind of heals up on their own. Might be caused by things like varicella, influenza, mumps, HIV, but generally it's self-limiting and it will resolve on its own. Meningitis is spread by direct contact with discharge from the respiratory tract. So as you can see, that's why it can be such a risk factor for these college kids who are, living 2 kids in a dorm, or, maybe 5 kids in a small apartment, because of their close living proximity. So that is one of the new requirements, is that people get the vaccine before they go off to college. So interventions that we need to do, always remember that meningitis can be fatal, especially the bacterial type. They're going to need Tylenol, not for pain, but to keep that fever down, to keep any further problems from occurring because of a high fever. Shivering, we want to try and keep them from shivering, because it's with their fever, especially if their fever gets really high and they get the chills, because when somebody has a high fever and their chills and they're shivering, there's more demand for oxygen and glucose. So we need to keep their fever. Sorry, I'm trying to do too many things at once. We need to make sure we're giving them Tylenol to keep that so that their body isn't demanding more oxygen and glucose than it already is demanding. These people need to be in a quiet, dark environment, generally isolation. Trying so they aren't using any of their energy, so they're not getting exerted. Basically, we need to keep their stimulus down. We need to make sure we're giving them antiemetics. We do not want them throwing up because that will cause problems with their ICP. We're going to give them broad spectrum antibiotics to kill all of it, like Vanco or Rocephin. Steroids, because we want to decrease any type of swelling that's going on. Generally, we're going to be given mannitol, like I said, to control their intracranial pressure. Generally, that's what will cause death in these people, is the ICP will get out of control. Oh, I did forget to mention back on this slide, the bacterial meningitis, why the glucose level is decreased is because bacteria actually feed on sugar. So anytime there's a bacterial infection, especially when the bacteria are in the CSF, they're going to be eating all that sugar. So all their glucose levels are going to be low because they can't keep up enough sugar in their body to keep the bacteria happy. Some of the weird little things I have in my brain. All right, encephalitis. We only have one slide here of encephalitis. This is inflammation of the brain tissue, where meningitis is inflammation of the meninges. Encephalitis is inflammation of the brain tissue. Generally, it's a viral cause, can be caused by things like parasites, toxic substances, can be a bacterial, can be caused by ticks, mosquitoes, even herpes simplex 1, because that herpes simplex will be dormant in the body and then all of a sudden it'll pop up and cause encephalitis. Symptoms that we will be looking for is like fever, headache, seizures. Generally, it's the same thing as like flu-like symptoms. So people kind of poo-poo it at first. Trying to think what else can cause. Mono or mumps can actually cause encephalitis as well too. Things that we need to diagnose encephalitis. There's going to be CTs, MRIs, lumbar punctures, just to make sure that it's not going into meningitis, see what type of bugs we've got. Interventions for nursing, we're going to control their symptoms. We're going to educate their family. And if they're home, I mean, they need to be watched closely because if there's encephalitis, generally times they're going to be confused. They're going to have an altered level of consciousness. And they need to be treated ASAP. The most common time is within the first 72 hours that someone will die from encephalitis because the edema and the necrosis of the brain tissue actually can cause the increased intracranial pressure and actually cause that brain to herniate. And that's what will cause death from encephalitis. There is actually a lacrosse encephalitis strain. I think the last count of it, like 2018, was like 68 cases. But this is transferred from like a mosquito. If the mosquito is infected and it bites somebody, they can actually transfer the lacrosse encephalitis. Generally, you'll see more neuro symptoms with kids, especially under the age of 16. And it's not very common. If you think about 68 cases, that's worldwide, nationwide, I'm not sure, either one. But it's actually more common in like Ohio. Um, but what happened was in 1965, there was a child who died of an unknown infection, and they couldn't figure it out. So through research and testing, they found out that it was the bite from a mosquito, and that actually happened here in La Crosse, and that's why it's called a La Crosse encephalitis. All right, neurodegenerative disorders. So I wanted to take just a minute here and kind of go over a few things with neural system and aging. Dementia is not a normal stage of aging. I want you guys to remember that dementia is not a normal stage of aging. People might become more confused and forgetful, but they don't. Dementia is not a normal stage. So, a decrease in their mobility and their sensory perception is the most common issue with neuro in the elderly. Basically, they've got slower movement, slower response time, and decreased sensory perception. So they don't feel like if they touch a hot stove, they don't feel it as hot as fast as we do now. They have a slower processing time. Recent memories are sometimes lost. So that's like short-term memory loss is effective first. They might have a decreased sense of touch. They have a change in their perception of pain. I've seen this in elderly. I have a 85-year-old female and a 50-year-old male. Had the same surgery, both had a hip replacement. The 85-year-old female will say, yeah, well, my hip's kind of bugging me, so maybe when you get time, if you could just bring me one Tylenol, I'll be okay. And I have the 50-year-old male saying that he needs something like ketamine to get through the pain. So I think they really don't process pain like they did when they were younger. Elderly have a change in sleep patterns. Their circadian rhythm changes. Early to bed, early to rise. If you've ever worked in a nursing home, you know some of these people are going to bed at 5:30. They eat supper and go straight to bed. And it just gets to be kind of their habit. Obviously, they have an altered balance and decreased coordination, which puts them at a huge risk for falls. So we just really need to make sure we're giving them assistive devices. They're at an increased risk for infection because, yes, this has to do with the neurosystem. There's deterioration of the microglia, which are the cells that are responsive for cell-mediated immune response in the CNS. So, yeah, they do have, a few things stacked against them when they get older. Some other things that we need to be aware of. A lot of times their pupils are actually going to decrease in size, so that's why elderly need more lighting. They need more lights to see better while they're walking around. But their pupils actually adapt slower. Sometimes they have subtle memory changes. Like long-term memory generally is kind of fixed, and they can remember what happened in 1942, but they can't tell you what they had for supper last night. So elderly are more likely to nap in the afternoons. Guess that means I'm old. I wish I could nap in the afternoon. And just an FYI, lack of sleep actually worsens dementia. So the less they sleep, the worse their dementia gets. And then, last but not least, in the elderly, a change or a decrease in their mental status, like acute confusion, generally is a very early sign, not very early, but a key sign of an infectious an infectious process in an older adult. For an example, like a UTI, one of the first symptoms we see with them is confusion. So All right, now that I got my elderly speech out of the way, we can move on to dementia. Dementia, um, hold on, I gotta go check on the kids. All right, let's try this again. Apparently my house is a revolving door for everyone. Oh, now we're lighting fireworks off next to my house. Oh, I'm so sorry, guys. All right, we're gonna try this anyway. I will have 3 dogs in my lap pretty soon. So, anyways, dementia. Dementia is the umbrella term for all of the like Alzheimer's, vascular dementia, Parkinson's dementia. So dementia is just the term that the umbrella term. Can be a disease in itself, but generally it's a symptom of other disorders. And like I've stressed a million times, it's not a normal part of aging. And pathophys really kind of depends on the cause, whether if it's like it's vascular dementia, maybe they had a stroke in the past. If it's Lewy body dementia, maybe they have Parkinson's. So it just kind of depends on what the cause is. So here are the examples, the vascular changes, blood flow to the brain is maybe a person had a stroke in the past, and that's what's causing the dementia. Or the neurofiber changes, basically the brain structure of the brain is different. Dementia is basically a chronic progressive cognitive decline. The onset is slow, takes months to years. Trying to kind of go over. I think we go in to Valentia. All right. I apologize, guys. I'm spinning in about 18 different directions. So delirium is different than a dementia because delirium is temporary. It's has a rapid or can be gradual, but generally it's more rapid. A mental disturbance, temporary. It's disorganized thinking, unable to stay focused, caused by a stressor, like if there's pain, maybe they're hypoxic, maybe there's an electrolyte imbalance, those types of things. Delirium can be reversed, whereas like dementia cannot. Sometimes we'll see it in ICU as a psychosis patient. All right, Alzheimer's disease is a type of dementia. It's a progressive degenerative disease that eventually these people will forget how to do certain things like eating, and even breathing becomes an issue. So eventually it will become fatal. All right. Pathophysiology, the cause is really unknown, but there's an abnormality in the neuron. There's what's called neurofibrillary tangles and neuritic plaques that are found in the brain at autopsy. There's no way to test prior to death if it's Alzheimer's, but after they die and an autopsy is performed, they'll see these neurofibrillary tangles and neuritic plaques. But that's basically the only diagnostic for Alzheimer's. Alzheimer's was discovered in 1907. So it's been around for a long time. I'm sure it's been around a lot longer than that, but first case was documented in 1907. It does generally have a set stage, like the beginning stages, the early stage lasts about 2 to 4 years, but you're going to see people with increased forgetfulness. The middle stage, it'll last anywhere from 2 to 12 years. where their cognition is just deteriorating. They might be irritable, they might be depressed, they're going to be wandering, anxious, and they're not even going to have a thought to their personal hygiene. That's where we come in, where our family comes in and they need to do complete cares. Late stage, um, they're completely dependent. These are the people you see sitting in the hallways in the Broda chairs. Um, they basically they aren't able to recognize family. Um, they aren't able to even feed themselves anymore. So that is the late stages of Alzheimer's. Um, Nursing interventions for Alzheimer's. I can't stress enough um, validation therapy. If you have a patient who is confused and thinks you need to go out and milk the cows, you're going to go out and milk the cows, darn it. Um, that's one of my patients. It was kind of a joke that every time I walked into work in the morning, I'd go in, check on her, and she'd be worried about Pa being out there milking the cows because it was, 40 below and it was July. Um, so I would always go out and say, nope, I'll go tell Pa to come inside. He can warm up and I'll go finish the cows every morning. But it calmed her down and it kept her in bed for another 2 hours. So validation therapy, validation therapy, validation therapy. We need to keep our environment calm. If the caregiver is stressed out, it's going to transfer to the patient. Keep their area familiar to them. Try and keep them busy. You see people carrying the baby around or maybe folding washcloths. So try and keep them busy and slow down when you're taking care of them. Don't be in a rush. Um, they really have no control over this. So the more time you can take with them, the better. I've really seen wonders with music therapy and Alzheimer's disease. I'm going to pause and try and figure out something to do with this dog that keeps pacing because of the fireworks. All right, let's try this again. All right. Um, Medications for Alzheimer's disease came out in like 1996. Um, they basically stop the breakdown of acetylcholine. They don't reverse any of dementia symptoms or Alzheimer's symptoms, but they slow the decline. So there's Aricept or Epsilon, um, and then the other one is Namenda. So they 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 do help, um, but generally um, if they've already lost so much, it doesn't bring that back. Like if they are to the point where they are not recognizing family members, giving them Namenda or Aricept will not help them recognize their family members again. All right, Parkinson's disease. Um, Parkinson's disease is a chronic degenerative um, movement disorder. So basically, the substantia nigra, um, there's a death of the substantia nigra, which decreases the dopamine production um, and increases the acetylcholine because the dopamine is needed to turn off the acetylcholine. Well, when there's too much acetylcholine, you're going to see the key symptoms of Parkinson's, the tremor, the muscle rigidity, the akinesia. Um, the brain is not able to tell the muscles how to perform, and they kind of get hyperexcited, um, and they're basically, if you've ever seen anybody with Parkinson's, they're tremor, they're tense, they're spasming. Just kind of looking. So the symptoms that we see for Parkinson's, they're going to have a stooped posture. They're going to have this masked face. It's very like it doesn't show a whole lot of emotion. I don't know how else to explain it. Their trunk is going to be tilted forward. Their back arms. S is for speech. Is it slurred, or do they understand you? And time is critical. If you're seeing any of these signs, call 911 immediately. Sorry, my son was trying to sneak down the stairs right by my head, and the dog was not knowing who he was and was yelling at him. I told you my house is a zoo. All right, diagnostics. CT. Like I said, if it's a TIA, then the results are going to be negative. If it's an ischemic stroke, generally they won't see it on CT for a few days, but they will see a hemorrhagic stroke on a CT pretty quickly. An EKG, we're just looking for something that might cause a blood clot somewhere, like AFib or some sort of heart disease. Labs that are going to be done, CBC, PT-INR to check their clotting, obviously a pregnancy test, blood typing, glucose, because the brain needs lots and lots of sugar. And then a carotid Doppler might be done just to see if there's any stenosis or narrowing of those carotid arteries, just depending on what exactly the cause of the stroke was. Faster the patient's treated, the more brain function we can save. So obviously ABCs, oxygen vitals, heart rhythm, IV fluids, airway, breathing, circulation. Basically, assess the patient real quick, get their diagnostics done, and get back to treating them. So this is one of those things where they come in the door to the ER, you do your test real quick, and you start treating them right away. The big thing is the alteplase. It's called a clot buster. It's TPA, tissue plasminogen activator, because it will dissolve a clot and can actually reverse the stroke symptoms if this is administered within 3 hours. So that's why it's so important that they call 911 or get the patient seen as soon as symptoms are starting. TPA is actually it's like $3,000 a dose. So, but when you look back and see what the cause is, or what the what's the word, quality of life is after a stroke, $3,000 is nothing. Yeah, I think that's pretty much it. Oh, nope. I thought we were done with strokes. Long-term effects of stroke. It all depends on, like I said, how fast they can get treatment. But we're going to see things like paralysis. A lot of times these guys are prone to contractures. They're going to have swallowing issues. They might lose their bladder and bowel function. They might have decreased sensation. I've seen people that have had like if the affected side was their left-sided neglect because they just don't use that left arm anymore. So I've seen people, get it caught in between the wall and the wheelchair because they forgot it was there. It's just basically they neglect their left arm because they're not even aware that it's there anymore. Aphasia is a big issue with strokes when the speech center gets affected. So dysphagia is difficulty with speech. Expressive aphasia, the patient knows what they want to say, but they can't talk or they can't get the right words out. They can't make sense. Receptive aphasia, they're unable to understand like spoken or written words. And global is when they have expressive and receptive together. So how can we best approach patients' orientation level or pain level or other assessments when they have problems with aphasia? We can ask them yes or no questions. Are you having pain? Yes. Well, I really would like to know how bad your pain is, but if I can't get you to tell me 7, if you can tell me you're having pain, I'm gonna treat it. Um, are you hungry or, whatever. We can always ask yes or no questions. We can figure it out. And these patients are going to be emotionally labile. Um, they're going to be unstable. Like we're going to see people, stroke victims, they're going to be crying 1 minute, happy the next, and then crying again. It's a hard thing for families to understand. So, all right. Aneurysms. It's just basically a weakness in the wall of an artery in the brain. Um, Generally, people don't even know they have it. I have it on my dad's side. Um, my grandmother, my aunt, and 2 of my cousins actually um, have had aneurysms, and we are instructed that we have to do an MRI every, I think it's 10 years, just because there are really no symptoms to it until it ruptures. Subarachnoid hemorrhage. Basically, this is just bleeding in the space between the brain and the tissue covering the brain. Um, this is what happens with an aneurysm. So when the aneurysm ruptures, causes a subarachnoid hemorrhage. Sometimes there can be other causes like trauma, um, the arteriovenous malformation, but a lot of times this is going to be the aneurysm is what's going to cause this. You're going to see lethargy, irritability, nausea, vomiting, and a major headache. That's what actually my 2 cousins went in with, is they had been having headaches and they were severe and just couldn't take it anymore. And they were treated for migraines a couple times, and then finally they did the MRI and found the aneurysms. I'm gonna try and get my dog to settle down because he's starting to make me mad. All right, hold on. I'm gonna pause it again. All right, keeping on trying. Um, if you guys are listening to this and it is terribly disconjointed, which I know it is, but I have to work. I've got class tomorrow. I have to be there in Boston at 7:30, so I don't have time to redo the whole thing. Let me know how terrible it is and if I need to redo this, because I apologize. It's just been kind of a shit show at my house. All right. Moving on to multiple sclerosis. Multiple sclerosis is a chronic progressive degenerative disease. Um, it's an immune mediated inflammatory destruction of that myelin sheath, and replaces it with sclerosed tissue in the brain and in the spinal cord. So remember when I was talking about the um, axon and the myelin sheath covering, and it was like the casing on a hot dog? Well, this is the one that I was talking about. In multiple sclerosis, that casing um, is destroyed, and so the nerve impulses can't jump from hot dog to hot dog to hot dog to hot dog. It is disconjointed, like my lecture, and it ends up the impulses cannot be transferred from the brain to the muscles. So the contraction actually doesn't happen. It's caused by the immune system. That nerve becomes inflamed and edematous, and the impulses cannot, like I said, cannot be go from the brain to the body. Um, Symptoms that we're going to see, it's a very, very wide array of symptoms. Muscle weakness, tingling, numbness. When they bend their head forward or their neck forward, it's like an electric shock sensation. Sometimes it happens suddenly, sometimes it can happen over 20 years. Um, there's different things that aggravate it and cause the exacerbations or the attacks. Obviously, it's like heat, cold, infection, stress, hormone changes. It's really kind of a very difficult disease, illness. Um, these people are going to be extremely fatigued, and eventually they'll become immobile. Um, one of my friends actually passed away about 2 weeks ago, and multiple sclerosis was a contributing factor. Um, her symptom, she got up one night to go to the bathroom, and in the middle of the night, she sat down to pee, and when she went to stand up, she had no movement in her legs and fell straight to the floor. So they thought it was a Guillain-Barré symptom, but looking further into it, it was multiple sclerosis. And it was so sad to see. She's my age. She was my age. Um, and the disconnect between what she was telling her muscles to do, it just wouldn't happen. And she was very jerky. And it was just really sad. Um, so, like I said, diagnosis is pretty difficult just because not everybody presents the same or has the same issues. The MRIs will show those sclerotic plaques on the myelin sheath. Sometimes the CSF will show an increase in the IgG, and basically it's a rule out other diseases. So here is a nice thing to kind of show the different types. I want you guys to know the types. There's a relapsing remitting, which I think is the most common, but there's unpredictable attacks. Might leave permanent deficits, might not. Um, so you can see on here where they spike up where the attacks are, then they are at their baseline, then they spike up and leave a little bit of deficits, and then they have their baseline, then they spike up, and it just continually gets worse. There's primary progressive, which is a steady progression of the disease. There's no attacks, but they just steadily progress and the disease becomes worse. Then there's secondary progressive MS, where there's initial relapsing remitting with the attacks, and then they begin to have the decline without the attacks, just a steady decline. These pictures should actually be going the other way to make a little bit more sense, but it's an increase in the decline, if that makes any sense. And then there's a progressive relapsing, where they never return to their baseline. They're just a steady decline, attack, steady decline, attack, steady decline, attack. This is just the picture of the axon with the myelin sheath. So you can see where the scarred myelin is there. And so the impulse would have to try and jump over that hot dog. So the muscle movements are pretty twitchy and jerky. Symptoms of MS are visual disturbances. They might have blurred vision or loss of vision, eye pain. They might have loss of their sensations, like their speech. They might have tremors or dizziness. Weakness, limb weakness, loss of coordination and balance. They might have bladder and bowel dysfunction. I know when my friend first lost control of her bladder, it was a sad day because we were out and about, and all of a sudden she's like, "Lise, do you have any shorts in your car?" And I was like, "No, what's up?" She's like, "I just pissed myself." And we made a joke out of it, but it was just sad because her disease was just progressing. They may have mental changes. memory loss, depression, paranoia, uncontrollable laughter, and then muscle spasms, fatigue, numbness, or this prickling pain. So you can see it's a pretty terrible illness. Um, Medications. There's the interferons. Most common is Avonex. I used to run around the country and teach it. Well, not the country, state, I should say, and teach newly diagnosed MS patients how to use Avonex and inject themselves. What that is an immune system modulator that has some antiviral properties. So it basically decreases the inflammation that's causing the damage to the nerve cells. It's a wonderful medication. It works wonders in a lot of people. Um, Anticonvulsants, they might be used basically to relieve the neural pain. Um, what's gabapentin is another one that might be used. Muscle spasms, they're going to use things like diazepam, baclofen, Xanaflex. Um, Nursing interventions basically treat the symptoms. Other meds are going to just depend on what their symptoms are. They're going to be in rehab, like PT, OT, speech, um, home adaptation devices, support groups, counseling. Sometimes they can actually do a plasmapheresis where they're doing a plasma exchange so that they're taking the antibodies that are um, attacking the myelin sheath with fresh plasma, but I don't know how common that really is. And the best thing we can do is educate our patients to try and decrease the things that will cause an exacerbation. So if they're stressed out or their routine is messed up or, um, you know, those types of things, making sure that they know that it's okay to be a little anal when it comes to making a routine and sticking with it. Myasthenia gravis is Greek for grave muscle weakness. So it's weakness of the voluntary or the skeletal muscles. So it's an um, autoimmune disease that causes weakness in the skeletal muscles. So eventually, they're what are responsible for breathing and moving the parts of the body. Um, it is a chronic autoimmune response. And the thymus, remember we talked about in the immune lecture, um, where it stores all the antibodies. Um, Generally, this is what the cause is that thymus um, triggers this autoimmune response and the body attacks itself. So we're going to see things like muscle fatigue uh, with activity. Once they rest, they actually get their strength back, but if they do much, they're losing their strength. We're going to see ptosis, which is like eyelid drooping, chewing, swallowing, speaking, and eventually they'll have breathing problems because the muscles that are responsible for helping them breathe um, will fail as well. Complications we'll see with it are aspiration because they're having problems with chewing and swallowing, respiratory infection because they're not able to expand their lungs um, like they did before they were diagnosed with myasthenia gravis. And eventually respiratory failure will happen. It is the leading cause of death for the myasthenia gravis population. Uh, there isn't a whole lot of things that are going to be like, yep, this is straightforward. These are diagnostic tests. There's basically based on their symptoms. So if they look up for 2 to 3 minutes, the eyelids will droop. Um, Nursing interventions. Um, We need to educate our patients on dietary, so that they are eating the foods or thickened liquids or whatever it may have you, um, so that we're preventing aspiration. The activities that they can do that's not going to cause too much of a loss of their strength, and symptoms of a crisis in myasthenia gravis. There is no cure. Um, we need to make sure we're teaching them to rest in between activities. Um, and we need to teach them how to take their meds. Take them as prescribed, but we need to make sure that they're taking them so that their peak of their med happens when they need their muscle strength. So, like, if they need to take a shower or a bath, they're taking their meds so that they are doing their best that they can be when it's time to be in the bath. So, basically, schedule their activities um, around, or their meds around their activities. Myasthenic crisis. This is just a sudden exacerbation of the motor weakness, which really puts them at a huge risk for respiratory problems. If they're not taking their meds as prescribed and they're under medicated, and maybe they missed a dose, or maybe they have an infection brewing, is when we're going to see this. So we're going to see their heart rate's going to elevate, their respiratory rate's going to elevate. They're going to have a severe respiratory distress. They're going to have dysphagia, restlessness. They're going to be anxious. A cholinergic crisis is like basically sludge. There's too much meds. They're gonna be too much. There's gonna be too much drool, like salivation or drooling. They're gonna be tearful. They're gonna be peeing a lot, diarrhea, GI cramping, emesis. Basically, they're gonna have liquids coming out of every hole. And it is an emergency situation. ALS, or Lou Gehrig's disease, um, is another sad disease to watch. Um, it affects the motor neurons. They start to degenerate and then form scar tissue, die. Basically, they're not able to transmit nerve impulses. Um, I'm not reading exactly how this is understanding, but basically there's atrophy of muscle tissue, strength. Um, it is a very rapidly progressive muscle wasting, and eventually will be fatal. Um, respiratory muscles are affected in ALS, so eventually they will. Sorry, I'm trying to catch my train of thought again. Eventually, these guys with ALS will most likely die from things like respiratory distress. Symptoms that we're going to see is there's a lot decrease in coordination of their arms, leg, trunk, which eventually leads to the breathing issue, like I said. They're going to eventually be on a ventilator at home. You're going to see lots of things with malnutrition. They may fall if they're not in a wheelchair yet. You might see things like pulmonary emboli because they're not able to use their get up and move like they normally would, or breathe, take the deep breaths like they normally would. You might see CHF in these folks, and generally death happens pretty quickly after diagnosis, 3 to 5 years. Diagnostics is there's really no specific test, just based on signs and symptoms and tests that ruled out other diseases. Medications that we're going to see with ALS: baclofen and diazepam, that's going to decrease their muscle spasticity. Quinine to help with the muscle cramps, and Riluzole might help prolong life a little bit longer. Um, nursing interventions for ALS: obviously OT, PT, OT to kind of help and get them situated at home so they can live out as long as possible at home. PT to help with like falling. We need to watch for aspiration and contractures. Um, keep changing their positions. Maybe different activities for pain control. Eventually, these people might be on tube feedings. Huge risk for infections. Um, we need to take care of their skin care. They're a huge risk for UTI. Eventually, they'll need other forms of communication, whether it's like a one of those boards or however. Um, basically, what ALS is, now that I've gone through the slide, um, ALS is a progressive disorder which attacks the body. So basically, this person who is diagnosed with ALS, they might have go in for maybe they're stumbling and um, they're not really sure what's going on. They can't get their lower legs to or their legs to work properly. Get diagnosed with ALS, and they basically watch their body shut down. ALS does not affect the brain, the mentation, the cognition, any of that, but it affects every part of the body. And basically, these people watch their bodies shut down. Um, I've taken care of a few people with ALS, and it is honestly, I know I keep saying it, but ALS is probably one of the most heartbreaking diseases I've ever seen in my life. Um, I took care of a guy at home who had two young daughters. He was in a mechanical wheelchair that he controlled with a straw. He had a drive-in shower. He had a communication board. Um, it was just, it was terrible. I cried every time I went and visited them. Oh, we are almost done, guys. Guillain-Barré is an inflammatory disorder with an abrupt onset, um, with symmetrical weakness that eventually will lead to paralysis. Um, it's another thing where the myelin sheath of the spinal and cranial nerves is destroyed because of inflammation, um, infiltrated by lymphocytes, takes that um, myelin sheath off, and actually slows or blocks the nerve conduction. Eventually, those myelin sheaths will restore and the symptoms will resolve. So Guillain-Barré um, will resolve eventually, but it takes a little while. Sometimes these guys actually have to be on a ventilator. Um, cause of Guillain-Barré not exactly understood. Um, sometimes if they've had an infection a few weeks before the onset of symptoms, but eventually 80 to 90% spontaneously recover. Um, ascending is the most common, where the weakness and the numbness start in the legs and goes up the body and leads to paralysis. Descending is not as common. It's going to start with difficulty swallowing and talking, and then progresses downwards to the legs. Affects the respiratory system pretty quickly. Signs and symptoms of Guillain-Barré. The first stage is basically the onset of symptoms within 24 hours to 3 weeks of the infection. You're going to see rapid onset of muscle weakness and paralysis. Second stage is the plateau stage. It lasts anywhere from 2 days to 2 weeks. Symptoms are the most severe, but it's not progressing anymore. It's just basically plateaued. And then the third stage is the recovery stage, where those axons are the myelin sheath is being restored, can actually last up to 2 years. Symptoms will slowly improve. Complications of Guillain-Barré. The main one is respiratory failure. Then there's infection, might be depression. These guys might have problems breathing, obviously, and have to be intubated. UTI, skin breakdown, obviously, all the immobile issues. PE, DVT, muscle atrophy. No specific test for diagnosing Guillain-Barré, but it's just based on their symptoms. Sometimes a lumbar puncture will show increased protein levels in the CSF. Nursing interventions. These patients are going to be anxious. They're going to be scared. They're probably going to be on oxygen or even a vent. Might need plasmapheresis to have the body quit attacking itself. We need to manage pain. Sometimes we're going to even go as far as a tube feeding, a communication board. Um, if these patients are feeling a little bit better, they might actually get pretty bored themselves. Trigeminal neuralgia is also called tic douloureux. It's a chronic disease of the cranial nerve number 5, and it causes severe facial pain. Not really sure what the exact cause is. But cranial nerve number 5 has 3 branches. The upper branch affects the eye, the upper eyelid, and the forehead. The middle branch is the lower eyelid, the cheek, the nostril, the upper lip, and the upper gum. And the bottom branch is the jaw, the lower lip, and the lower gum, and the muscles for chewing. So if you can see that when there's damage to this nerve, um, why it's causing all that pain in the face. Signs and symptoms, obviously, the pain's going to start and end suddenly. It actually occurs in clusters, and many things can actually start that pain. Touching the face, eating, swallowing, if they have a temperature. Generally, it's unilateral, and they might have pain attacks up to 100 times a day. Starts generally near one side of the mouth, goes up to the ear, eye, or the nostril, so you can kind of see where that. Sometimes sleep will help, but episodes can last a long time. Diagnostics, CT or MRI, just to rule out other causes. Basically, the meds will work after a while. Anticonvulsants they'll be taking. They might be given a nerve block for their face. Sometimes that can help up to, I don't know, a year and a half. And some surgery can actually remove the cause of the irritation. And then our last one is Bell's palsy. Basically, facial nerve number 7 is inflamed and edematous, and the nerve impulses aren't working, so it actually causes paralysis on one side of the face. Can be caused by viral or bacterial infection. Lyme's disease is a huge factor in this. Signs and symptoms, we're just going to see it's going to look like the person actually had a stroke. So loss of motor control on one side of their face. They're not going to be able to close their eyelid, wrinkle their forehead, smile, raise their eyebrow, close their lips. So that one side of their face is completely paralyzed. Generally, the recovery is less than a year. And medications include like prednisone to decrease that edema of that nerve. Analgesics to help with the pain. A lot of times heat and massage will help a lot more than the pain meds. We'll give them artificial tears. Sometimes they're embarrassed with the drooling, and eating is a little bit difficult because one side of their face is paralyzed. And this is just what it looks like. drooping of the corner of the mouth, facial paralysis, and droopy eyelid. But I'm going to close here because my house is about to get crazy. If you guys are going through this and it's terrible, 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 please let me know and I'll try and redo it. But I just want to get this out because I've got class in the morning. All right, have a good night, guys.